Single ventricle and Fontan's physiology. Single ventricle describes a single well-developed ventricle and associated rudimentary ventricle. Very rarely is there a truly single ventricle lesion. A well-developed ventricle is composed of inlet portion and outlet portion to a great variety and trabeculated portion. A rudimentary ventricle describes incomplete ventricle or a ventricle lacking either an inlet portion or outlet portion or trabeculated portion. Hypoplastic ventricle describes complete but not well-formed ventricle. Initially, there are different classification systems used to describe what lesion counted as a single ventricle. However, in 2000, the Society of Thoracic Surgeons International Congenital Heart Surgery Nomenclature and Database Project created universal guidelines of what lesions would be included as functionally univentricular heart, and these lesions include double inlet atrioventricular connection, double inlet left ventricle, and double inlet right ventricle. Heart where one ventricle is lacking or has an atretic atrioventricular connection, the mitral atresia and the tricuspid atresia. Heart with a common atrioventricular valve and only one with developed ventricle, unbalanced atrioventricular septal defect, and hypoplastic left heart syndrome was given its own classification, still recognized this lesion as functionally univentricular lesion. The single ventricular physiology. In the single ventricle lesions, the pulmonary and systemic circulation is in parallel rather than series. Because of this, the patients are dependent on maintaining adequate systemic output along with appropriately restrictive pulmonary blood flow. Intervention to restrict pulmonary blood flow include either increasing pulmonary blood flow when it is adequate, that is the aortopulmonary shunts, or decreasing the pulmonary blood flow when it is excessive, that is the pulmonary artery banding. The goal is for adequate oxygen delivery without overworking a single ventricle, though excessive volume load without damaging the pulmonary vasculature for overcirculation. For the straight ventricle palliation, the patient are dependent upon the low pulmonary vascular resistance and end diastolic pressure due to passive pulmonary flow. Initially, the systemic ventricle sees at least double the typical volume load and sees the pulmonary and systemic circulation, when eventually it leads to dilation and the ventricular failure. The left untreated patients with single ventricle lesions have high mortality due to eventual ventricular failure. Single ventricular lesions with ductal dependent systemic output are universally fatal with first week of life of ductal closure. The single ventricular lesions with ductal dependent blood flow will present early on the profound cyanosis and ductal closure. Most patients with single ventricular lesions will require surgical intervention in the first few weeks of life unless they have a perfectly balanced systemic output and pulmonary blood flow. There are a variety of the lesions that lead to single ventricular physiology. And there are tricuspid atresia and hypoplastic left heart syndrome. The tricuspid atresia are variable presentation at birth, eventual palliation of the Fontan procedure, best long-term survival of all single ventricles due to systemic left ventricle. Hypoplastic left heart syndrome includes the aortic and mitral atresia. Most severe form of hypoplastic left heart syndrome need multiple surgeries, and survival rates has improved over time and relies on systemic right ventricle. And the complications that can happen is the RV failure, tricuspid regurgitation are common. The double inlet atrioventricular connection. Both atria connect to one ventricle either more commonly as a separate AV valve or a single AV valve, and there is usually a rudimentary ventricle associated with functionally systemic ventricles, and the rudimentary ventricle often lacks the inlet portion. The conduction system is abnormal, and the AV node can be positioned anywhere along the right side of the AV valve, and there is usually two coronary arteries. Double inlet left ventricle is a more common than double inlet right ventricle. In double inlet left ventricle, the systemic ventricle has a ventricular morphology. The aorta commonly arises from the rudimentary left-sided morphological right ventricle, and the pulmonary artery arises from the functional right morphology and the left ventricle. A double inlet left ventricle, the rudimentary ventricle usually does not have the outflow through the great artery. Thus, the lesion commonly presents with double outlet right ventricle of the aorta arising from the functional right ventricle and pulmonary atresia from the rudimentary ventricle. The mitral atresia describes an absent left AV connection leading to rudimentary left ventricle. Thus, for survival, the patient must have the atrial septal defect and a ventricular septal defect between the systemic ventricles, and the rudimentary ventricle is also commonly present. Most commonly, the left-sided AV connection is completely absent with no valvular apparatus. The outflow tract from the rudimentary ventricle can either be atretic. Mitral atresia with aortic atresia is a subcategory of hypoplastic left heart syndrome and covered with mitral atresia, and the patient with aorta commonly presents with either double outlet right ventricle or the aorta connects to the rudimentary left ventricle and is associated with hypoplastic arch. Unbalanced common atrioventricular septal defect. The unbalanced common atrioventricular septal defects describe a common AV connection where the axis of the AV connection is shifted such that one ventricle is more favored than the other, resulting in the hypoplastic ventricle. Thereby, a smaller ventricle is usually not rudimentary but the hypoplastic due to the flow defects. The location of the atrioventricular valve along the axis of the interventricular septum determines the extent of hypoplasia and which ventricle is favored. In common, atrioventricular valve is more right-sided, and the right ventricle will be systemic and the left will be hypoplastic. Next category is functionally univentricular heart with heterotaxy syndrome. The heterotaxy syndrome describes the failure of the right and left differentiation of the thoracoabdominal organs and result in anomalies of the systemic and pulmonary venous connection, abnormalities, the abnormal organs, and heart defect. Patients with heterotaxy are further classified by asplenia, absence of the left-sided structures, bilateral right-sidedness, polysplenia, and patients with asplenia often present with bilateral sinoatrial nodes, hypoplastic sinoatrial node, and the bilateral bilobed lung. Patients with heterotaxy syndromes often present with double outlet right ventricle and have other associated congenital heart defects, including the anomalous pulmonary venous return. Tricuspid atresia with anatomical variation, also called as hypoplastic right heart syndrome. Atretic tricuspid valve, a small right ventricle fed with VSD, obligated right to left flow across the atrial septum, and normal or malposed great arteries, plus minus coarctation. Hypoplastic left heart syndrome, aortic atresia with severe stenosis, mitral atresia with stenosis, hyperplastic LV, arch obstruction, ductal and PFO dependent. Pulmonary atresia with intact ventricular septum. Some can undergo two ventricular repair with RV large enough and no coronary arteries and dependent on the high pressure of the RV. Those with very small RV and RV dependent coronary circulation require Fontan palliation. Major risk is ischemia and sudden death. The double inlet single ventricle is also common. Unbalanced AV canal and primitive heart with single atrium can be seen. The surgical palliation of the single ventricle physiology has evolved significantly since the development of Blalock-Taussig Thomas shunt in 1940s and the pulmonary artery banding in 1950. Previously, the surgical techniques include the septation of the single ventricle in the pulmonary artery and systemic circulation system. However, the outcomes were poor of this technique. The right-sided single ventricle, that is the tricuspid atresia, were first studies work in animal models found to have a lower pressure. Right-sided circulation did not require pumping from the right ventricle to move the blood through the pulmonary circulation. This led to cavopulmonary shunt and commonly known as the Glenn shunt, where the superior vena cava is anastomosed to the pulmonary artery. Fontan's first operation used the Glenn shunt and was anastomosed to the right atrial appendage and the proximal right pulmonary artery. This bypassed the first ventricle entirely as directed all venous return directly to the lungs. With the success of the Fontan operation, application began to extend to the lesions with the hypoplastic or rudimentary left ventricle. After more experience, it became clear that the right atrium and the rudimentary ventricles were not needed to pump to the pulmonary circulation and could be bypassed entirely through the total cavopulmonary connection. The key components leading to be successful in cavopulmonary connection dependent on the widely patent connection between the venous system and the pulmonary arteries and the low pulmonary vasculature resistance to promote the forward flow in the passive venous system and adequate function of the systolic and diastolic and systemic ventricle. Many patients with single ventricular lesions will require a procedure as a newborn, either relieve the systemic outflow obstruction and or appropriately restrict the pulmonary blood flow, and patients with systemic outflow obstruction will require a procedure such as Norwood operation. In the absence of the systemic flow obstruction, it is necessary to determine if the pulmonary blood flow is appropriately restricted. The goal situation should be around 70 to 80%. If the patient have evidence of the ductal dependent pulmonary blood flow, they will undergo either systemic to pulmonary artery shunt or the ductal stent placement. If the patient have evidence of the excess pulmonary blood flow, saturation between 80 to 85%, the restriction of the pulmonary artery band should be considered. In the pulmonary blood flow is appropriately restricted, surgical intervention can be deferred until this cavopulmonary connection. The introduction of the superior cavopulmonary anastomosis bidirectional gland or the hemifontan is an intervening procedure to remove the volume overload from the single ventricle has dramatically improved the overall outcome. In the current era, conversion to Fontan circulation is performed in two stages to reduce the volume overload and systemic ventricle early to help preserve the long-term ventricular function. Superior cavopulmonary connection is performed either by hemifontan or bidirectional gland procedure. This is performed to offload the systemic ventricle, usually 4 to 6 months of age, and allow the child of pulmonary vascular resistance to reach nadir. Any associated defect that need to be repeated, such as anomalous pulmonary venous connection, AV valve insufficiency, should be performed during this stage as opposed to waiting until the completion of Fontan. The bidirectional gland cardiopulmonary bypass is established by the bicaval cannulation with a higher superior vena cava cannulation and the pulmonary artery as a patch augmented if there is any narrowing. The SVC is transected and anastomosed to the right pulmonary artery in an end-to-side fashion with ligating and dividing the azygous vein. The cardiac end to the SVC is oversewn. In a hemifontan, cardiopulmonary bypass can be established with the bicaval cannulation. An incision along the right atrium extending to SVC is made, and the central pulmonary arteries are opened widely, and rightward extension of the pulmonary arteriotomy is anastomosed to the posterior aspect of the SVC. The inferior aspect of the pulmonary arteriotomy is anastomosed to the posterior aspect of the arteriotomy, and the PTFE patch is placed in the right atrium near the cavoatrial junction to exclude the flow from the SVC from entering into the body, and the atrium is redirected, and this flow to anastomosed pulmonary artery. The patch is excised at the time of the lateral tunnel to Fontan to allow the flow from the inferior vena cava to PA. Finally, a patch is utilized to widely augment the central pulmonary arteries anteriorly to complete the pathway. The total cavopulmonary connection, the IVC to PA anastomosis, is the final stage of single ventricle palliation, and this can be achieved through either a lateral tunnel Fontan or extracardiac conduit Fontan. This operation is usually completed around 2 to 4 years of age, and the patient tend to exhibit the progressive cyanosis with increasing venous return from the lower half of the body. D. Level first proposed the lateral tunnel Fontan in 1980, when he showed with in vitro studies that this method has less turbulence and more efficient flow, less energy loss, which is important in the passive pulmonary circulation, and which has been further supported by the computation of the flow dynamic modeling. Additionally, this method enables more equal distribution of the hepatic return to both branch pulmonary arteries, and which is important to prevent the development of the atriovenous malformation. And with this technique, an intraatrial tunnel is created using the prosthetic patch and the posterior lateral right atrial valve. The venous return from the inferior vena cava allows through the tunnel to the pulmonary arteries, and cannulation strategy of the cardiopulmonary bypass is bicaval. The right atrium is opened from the entrance of the IVC, and a patch separating the right atrium to the SVC is placed along hemifontan. This patch is excised, and PTFE patch is used to create a path from the internal orifice of the inferior vena cava to the prior hemifontan connection. The PTFE patch is incorporated anteriorly into the arteriotomy closure to complete the pathway. The extracardiac conduit is used to connect IVC and pulmonary artery. Grew in popularity. In this technique, the patients are initially staged with a bidirectional glen, and since this involves the placement of the fixed diameter tube graft, is usually delayed until the children are 3 to 4 years of age and roughly 15 kg. The cannulation strategy for the CVP is bicaval. The IVC is divided at the entrance into the right atrium. The cardiac side is oversewn, and the hepatic side is anastomosed in 18 to 20 millimeter PTFE tube graft, which is then anastomosed to inferior aspect of the central pulmonary arteries. Fenestration of the Fontan. The fenestration of the Fontan pathway acts as a pop-off valve for some venous return to bypass the pulmonary circulation in order to augment the cardiac output when the filling pressures are higher in the initial post-operative period. The LT fenestration is created by using a punch device to create a 3 millimeter hole in the PTFE patch, and the ECC is fenestrated, creating a side-to-side anastomosis between the right atrium and the conduit. As the child circulation adapts to new physiology, fenestration has been shown to decrease the pleural effusion and ascites in the early postoperative phase, and the majority of these fenestrations will close spontaneously. With the cavopulmonary anastomosis, the central venous pressures are usually 10 to 15 millimeters high. Normal central venous pressure is usually less than 10, and these patients have a central venous pressure of 2 to 4 times that of normal, which have the central venous hypertension. Additionally, the lack of pulsatility in the pulmonary vascular bed may lead to endothelial dysfunction, and this may cause the increased pulmonary vascular resistance and making it more difficult to the passively move blood through the lungs. And finally, the preload of the systemic ventricle is limited by what can passively be more through the lungs, and the systemic ventricle may have a diastolic dysfunction due to the prior volume loading and repeated operation, and this may further be compromised, compounded by the challenged preload as a result of increasing Fontan pressure. So the complications likely to elevated central venous pressure and a low flow, low venous state. There are a number of complications seen with the Fontan physiology. There are higher risk of developing thromboembolic complication. Etiology of the increased risk of thromboembolic events is not clear, though it is likely related to the flow-related venous state and the synthetic material. Because of this, all the patients are maintained on aspirin, and more aggressive anticoagulation such as warfarin may be required in the patient with increased risk factors for thromboembolism, including the arrhythmias. The bradyarrhythmias are also common in the Fontan's population, and it is suspected that this because of the arterial incisions, chronic exposure of the arterial tissue to the increased pressure, and possible damage of the sinoatrial node and the sinoatrial node blood supply during the surgery. The risk factors of the arrhythmias include the pre-exciting atrioventricular valve disease or the anomalies of the older age at the operation, heterotexy syndrome, presence of the sinoatrial node dysfunction, preoperatively operative approach, bidirectional gland. Hemi-Fontan has not been shown to be associated with development of arrhythmias. Patients with arrhythmias can be treated with pharmacological agent or go on to have a permanent pacemakers if there is a sinus node function. MACE procedures have also been performed in patients with refractory atrial arrhythmias. Fontan's patients have more prone to liver disease. Approximately 50% of the patients will go on to develop liver fibrosis, with approximately half of those of fibrosis going on to develop cirrhosis. In suspected the elevated central venous pressure in the primary driver for Fontan associated liver disease, and the primary risk factor being elevated central venous pressure and the amount of time of the Fontan repair. It is recommended that screening for liver disease and cirrhosis begin 10 years post Fontan, and when most clinically significant liver disease begin through the high risk patient, screening may begin earlier, and it is recommended to screen the laboratory volume, liver function, as well as non invasive imaging, and the gold standard for diagnosis of the liver fibrosis and the liver biopsy. Protein losing enteropathy is a unique complication of Fontan's physiology, where the serum protein are lost in the gastrointestinal tract, and this leads to immunodeficiency due to hypogammaglobulinemia, hypercoagulability due to loss of clotting factors, and dysregulation of the clotting cascade, edema due to lower oncotic pressure, and hypoalbuminemia and electrolyte disturbances. The patient may also develop plastic bronchitis, and where the proteins are lost through the lumen of the airway, and this leads to accumulation of the protein and cast in the bronchial tree and can lead to asphyxiation of the cast and are not expectorated. As many as 15% of the Fontan's patient may go on to develop PE, and this pathophysiology or is not definitely known, but is thought to be related to the altered lymphatic flow and increased hydrostatic pressure from the increased central venous pressure. It is important to note that many patients with PLE do not have the significantly higher central venous pressure compared to that of other Fontan patients. Thus, the risk of developing PLE is related to individuals' ability to tolerate the elevated central venous pressure. It is associated with very poor outcome, with 50% mortality at 5 years and 80% mortality at 10 years. Patients with new protein losing enteropathy should first undergo the cardiac catheterization to identify if there is anything inevitable that may lead to improvement of hemodynamics, such as venous pathway obstruction, systemic outflow obstruction, or atrioventricular valve regurgitation. A fenestration between the venous system and the systemic system may be created in the Fontan circulation to improve the cardiac output and reduce the Fontan's pressure, but will lead to decreased arterial saturation and may be prohibitive. Steroids and heparin are the staples for medical management. Sildenafil as a vasodilator commonly used to treat the pulmonary hypertension and has been used to promote the forward flow through the Fontan pathway, improving the preload and systemic ventricle and increasing the cardiac output studies for efficiency of sildenafil and treating the alleviating PLE and promising, but further research is needed in severe refractory cases. The heart transplantation may only be definitive treatment option. All the patients with congenital heart disease requiring the intervention in first year of life are at risk of neurodevelopmental delays. Through the Fontan, patients go on to have a normal development with regards to functional status, and the earlier ventricle volume offloaded, the lower likelihood of the diastolic dysfunction due to the passive nature of pulmonary blood flow. It is challenging to increase the cardiac output during the times of the increased demand. Thus, the Fontan's patients may have a decreased exercise capacity as compared to their peers, but generally have a near normal activity levels. Outcomes have improved significantly for Fontan's patients as there is more research and experience taking care of unique group of patients, and a perioperative mortality has improved significantly, and with experience center reporting the perioperative mortality or approximately 1 to 2%. The University of Michigan published a review of outcomes after 15 years of Fontan and included with 600 patients. The study reported 96% of hospital survival and 97% survival of the long-term follow-up. The mean follow-up was 50 months, and the majority of the patient has good functional status and a long-term follow-up of 97% reporting NYHA class 1 or 2 symptoms. Despite this, the patient with the Fontan physiology have a lower life expectancy than the average, and retrospective review of the Mayo Clinic studies outcome of the patient from Fontan disease over 40 years, and in this review, overall 10 to 20 and 30-year survival is 70%, 50%, and 43% respectively. When stratified by the operative era, survival improved with the later operative era, suggesting that the outcome and life expectancy is improving for these patients. Despite the advances that have been made in the care of Fontan's patients, most patients will ultimately require a heart or liver transplant in view of the several studies. Aging, failing, Fontan circulation approximately 20 to 30 years. The Fontan patients tend to be much higher risk than the adult patients awaiting the transplant, likely due to the presence of alloantibodies and liver disease. They also have significantly higher postoperative mortality because of this increasing research being conducted on mechanical circulatory support devices of the patient with Fontan circulation, and there have been studies published for both systemic and ventricular assist devices in patients with failing systolic function of the single ventricle, and the cavopulmonary assist device for the patient with poor ventricular flow. So these patients require good medical care, early school readiness, lifelong access to adult congenital heart disease, and funds for pacemaker, repeat surgeries, job training, and option for heart transplant. Cardiac rhythm issues are very common in pediatrics, and ICD can be used in some cases. Sudden cardiac death is also very common, and most patients have a primary arrhythmia, and the patients at risk are long QT syndromes, catecholamine polymorphic ventricular tachycardia, arrhythmogenic right ventricular cardiomyopathy, and Brugada syndrome. Overall survival rates for out-of-hospital cardiac arrest is low, and as with adult, witness arrest has better outcome. In the rhythm issues, need to assess the medication, catheter technique, and devices are needed, and time of the school work to see the physicians and have procedures. Thank you very much.